Yes. Next speaker to
Good morning.
curtail is talk.
Good morning, everyone. I thank Dr. Vijay for giving me this opportunity. I am going to talk about different procedures to correct astigmatism and marking axis for toric IOL. So we are in the era of refractive cataract surgery, and for all of us, cataract surgery is becoming easier day by day. We are all trained for phaco and everything, but the result of cataract surgery must be equivalent to refractive surgery, and which is the most difficult part of cataract surgery for all of us today. And in next 10 to 15 years, lot many patients of our refractive surgery, which we have already done in last 20 years, LASIK and everything, they are going to come to us for cataract surgery. So every day the cataract surgery, the surgery is much easier now. We all do. But the results, we have to aim for emetropia, because all our patients know what the technique and technology is available. So we all must agree and adopt as early as possible for toric lenses, toric procedures, what is available today. So time have changed now, not only to worry about surgical outcome, but also to worry about the post-operative refractive outcome of all our colleagues and all cataract surgeons. This changing mindset of ours due to change in patients' expectations in today's era of cataract surgery forces us to give total spectacle-free vision to all our patients. So nowadays, before we were talking about treating astigmatism more than 1.25, but today corneal astigmatism of 0.5 diopter even we can treat. We can easily treat without anything adding in our procedures. So approximately 30% of cataract patients have astigmatism that require treatment. We all know how astigmatism give difficulty in patient's vision. These are the myths. Very few patients lying in this group. No, more than 30% of patients need this type of treatment. Need not to correct, we have to correct. Patients never demand. Now the patients are very demanding. This is costly procedure. There are various things available and they are not very costly. We can correct by primary incision. All cannot be corrected, but few definitely that I am going to discuss. So what are the facts we usually avoid? We don't take call that we can do, we can treat astigmatism during cataract surgery. We don't do proper counseling of the patients. Fear of losing patient. मैंने समझाया कि टोरिक है, इतना पैसा लगेगा, patient कहीं और चले जाएगा. This is in our mind. Less accustomed on correction procedures like toric IOL, LRI, even arcuate incision with femto lasers. Lack of confidence on post-operative outcome. This is the most important thing which we all think in our mind. अरे यार वो एक नंबर का रह जाएगा तो क्या करेंगे? What Dr. Harbans was talking, we have to explain patients. थोड़ा सा रहेगा, but whatever we can reduce, we should. So these are the options available other than optical corneal incision on steeper axis. This is what I want to express much more, that even 0.5 diopter of astigmatism we can treat during cataract surgery. Start taking incision at steeper axis. 2.2 incision, do phaco, enlarge is 2.8 or 3 millimeter. We can at least reduce 0.5, 0.7 diopter of astigmatism for each and every patient of cataract surgery. Limbal relaxing incisions, nowadays we don't practice much of the limbal relaxing incisions, but toric IOL, smart toric IOL, I have done 14.5 diopter of astigmatism for cataract surgery with this smart toric IOL. Flex available, and then bioptics. These are all procedures available to all of us. So, but our first choice is always toric IOL. This is more predictable and better outcome is available. Now we have in our hand femto laser, which can correct the astigmatism during cataract surgery with the help of arcuate incisions. So these are the corneal single incision, pair incision, LRI, toric IOL, arcuate incision, these are all available. What is available, what is patient's choice, we can at least start treating toric astigmatism in our cataract patients. So this is about what the available measures are for treating cataracts cataract with astigmatism. Now what the tools are available to mark for toric IOL. हमारा सबसे बड़ा हिच ये है कि हम उसे मार्किंग कैसे करें. उसी कारण से हम लोग अडॉप्ट नहीं कर रहे हैं toric IOL in our cataract surgeries. So there are tools available. Now there are lot many softwares are available which automatically can give toric marking. So toric IOLs need proper alignment to provide refractive outcome in cataract surgery, and we have tools and softwares. So these are the tools available. What we need to do, we have to do two-step marking. One is reference marking and another is axis marking. So for reference marking, there are different markers available, and for axis marking, the Mendes ring and toric marker set is available. So what are the current gaps in toric marking? Pre-operative reference mark, we need 3 marks. 3 to 5 degree off here and there will change the results. Thick marks up to 3%, 3 degree or thin marks also gives different results. Implantation axis over pre-op reference marks. So these are the current gaps. So what are the solutions? Basic toric marking needs 2-step marking. Reference marking and axis marking. Reference marking, we need 3 marks, 3, 9 and 6 o'clock, and then we have to take the patient in operation theater and we do axis marking, that is incision location and lens placement. 1 for incision and 2 marks for lens implantation. If we want to avoid this 2-step marking, we have instruments, equipments in our own setup by which we can do reference mark, we can do incision location and implantation of lens, only this 3 marking in sitting position. Why we need this two? To avoid effect of cyclotorsion of eyeball in lying down position, we need 2-step. But we definitely can do with the help of slit lamp. So simple slit lamp in our OPD can give excellent results, equivalent to even Varion.
Axis of slit beam can be adjusted according to requirement of toric marking. This can be done from 0 to 180 degree. After installation of Paracel, ask the patient to sit upright in position, and after painting the Sinskey hook with the help of marker pen, adjust the slit beam and directly mark single point. Now we have to mark 2 points 180 degree apart for toric lens implantation. These are the 2 marks. This is how we can mark 2 points 180 degree apart for placement of the lens. This is the axis marks for toric IOL placement. Post-operative patient. In this patient, even on first post-op day, we can confirm the placement of the IOL in the bag, and we can confirm the exact axis of the lens implanted in the bag. This is the technique by which we can confirm the stability of the lens in post-operative period to see the rotational stability. Thank you.
So this is how we can mark only 3 points in sitting position. Now the lot of softwares are available for toric marking like Varion and Callisto.
Dr. O P, kindly conclude.
Yeah. So I'm not going in the detail of all these things. So this is by the help of Varion, we can mark in sitting position, and the same will transfer to our microscope in the operation theater, and we can have hardly 30 seconds I'll take. एक वीडियो चला दो. So we can take the incision at steeper axis with the help of this Varion image guided system, and lens is all implanted in desired axis with this image guided system. Thank you very much.
Thank you, Dr. O P, for